everyone. This is our last presentation of the day. We are going to hear from Lisa and Kate about nerve and tendon transfers. Lisa Schlee is a physiotherapist at the Community Accessible Rehab Program in Calgary. We call it CAR. Kate Elzinga is a plastic surgeon at South Elm Campus in Calgary. Take it away, Kate and Lisa.
Great. Well, thanks very much for having us. I'm going to present first and then Lisa will go after. So we are going to talk about surgical options for spinal cord patients. I trained med school here in Calgary and then residency in Edmonton, so it's nice to see a lot of familiar faces. I work at the peripheral nerve clinic here at South Health, and then when I was in Edmonton, I worked at the Glenrose. It's nice. We have big multidisciplinary clinics, and both clinics should be able to offer these options to patients across the province.
Can you share your slides one more time? Just can't see them.
Oh. You see it now?
Sweet, yeah.
Okay. That's just a picture of our team in Calgary. So we'll go through nerve and tendon transfers, indications, potential risk, complications, and as everyone's mentioned kind of all afternoon, it's obviously going to depend on the patient. So all the treatments are going to be tailored, but we'll kind of go through the most common things. So unfortunately, we don't actually probably do as many of these procedures as we could. Often patients are not referred, or they may not be interested in the surgery, or we just don't provide them with access to even get the information. So we're trying to do a better job at that. Patients certainly do not need to have these types of procedures. They are complicated. They have a long rehabilitation, but we just want to make sure that those that are candidates do have the information and the potential choice for this. So I'll just go through two cases. These are both patients from Unit 58. So if you work at Foothills, you may recognize them. This was a male patient who had a fracture dislocation at C6, C7, and he was lacking, I've kind of highlighted in red what his biggest problems were. So he did not have any elbow extension on his right side, and then he did not have any function through finger flexion or extension. We mostly use the Medical Research Council scale. So grade 1 is just a flicker. Grade 2, they can move without gravity. Grade 3, they can go against gravity. Grade 4, they can take some resistance, and 5 is a normal power. So we'll assess all these patients, and they will have some improvement spontaneously. So we don't rush into these surgeries. We want to make sure that they've had some time to have some recovery and see what they get before they embark on big surgery. This patient, his hands were very stiff. So often in spinal cord injury, we do let the hands get stiff so patients can have some tenodesis grip. But if they want to have surgery, it's a little bit of a different protocol, and their joints need to be supple, because if we put in new nerves or new tendons, but the joints are too stiff, it's not going to do anything. The next case, 60-year-old female, she was injured. She had, on her case, both elbows, so she did not have elbow extension on either side. And then she, again, did not have finger flexion or extension. And she was also on her left side missing wrist extension. And that's obviously a really big problem for patients, because if they don't have any wrist extension, they can't get any passive tenodesis. So highlighted in red were what we thought were her biggest problems that we could help with. In purple, she didn't have great forearm pronation or wrist flexion, but we only have so many donor nerves or donor tendons to move, so we can't address everything. So we do have to prioritize, and that obviously is done with the patient, what their goals are, and how we're going to make the best possible surgical plan. So upper and motor neuron, very important for us. If it's purely an upper motor neuron, there's no time rush at all. We can do the nerve transfer or the tendon transfer at any time. These patients will have disuse atrophy, but since the lower motor neuron's intact, that muscle is still preserved, and it can take new nerve supply years down the road. It's pretty amazing. But if the patient has a component of lower motor neuron injury, those are the ones that we do have to do within a window. They'll get a lot of denervation atrophy, and we have to do their surgeries within a year, because the motor end plates will totally degenerate. The muscle will become scarred, atrophic, and you can't put new nerve into that. But they can still have a tendon transfer at any time. But it's just if they want a nerve transfer, if they have lower motor neuron involvement, that has to be done within a faster time window. And we do unfortunately see a lot of patients with a mixed picture. So often we are fighting the clock a little bit. So what we do is we try to go from something that has volitional control above the level of injury And then we're trying to put a nerve transfer into a nerve below the level of injury, with or without an intact lower motor neuron, and then try to restore some volitional control and function to that. So this is just saying the same thing. The upper motor neuron patients, they do have retained tone and spasticity, and sometimes that actually works in our favor because it maintains that muscle bulk for us. What's kind of interesting in the nerve transfers, so you cut a donor nerve. So for example, if the patient has a spastic brachialis and you cut that nerve to move it, for example, to give hand close, that'll actually get rid of the spasticity in that brachialis muscle. So sometimes we get also some benefits of treating the spasticity when we take those donor nerves. We try to make a clinical diagnosis on the upper and lower motor neuron, but the electrodiagnostic testing is super helpful. So we've been very grateful for our physiatrists and the whole team at Unit 58 who are seeing these patients early and doing quite comprehensive testing for us to look at both the donors and the recipients. And then we can help figure out the timing for patients, first of all, and then what possible options they have. If they're not in that tight window, we would rather let them even maybe go a year or two, see what spontaneous recovery they get, how they do in the community after their injury, and then they can decide if they want to do a nerve transfer. And again, not all patients will go with it, and that's totally fine. So what we do is we have to find something that we can donate. So if you think about elbow flexion, we would typically preserve biceps for elbow flexion and supination, but we might take the brachialis nerve and the brachioradialis nerve, and then we can transfer those for hand close or hand open, for example. So we never want to make a patient worse. And we just have to make sure they actually have a donor. If they have a very profound injury with nothing to move, then they may not be a surgical candidate. We also want to make it synergistic. So if we would try to put a wrist extensor into finger flexor so that tenodesis is more natural and the rehab is easier. So highlighted in yellow, these would be often the patients that we would see. They have the intact, predominantly C5. So they would often have intact deltoid, elbow flexion, and supinator. So those would be some of the donors we would take. And often what they're missing is in blue. So the predominantly C7, C8. So they're often missing hand open, hand close, and triceps. So that's what we're working on. If they're missing in green wrist extension, that becomes a high priority for us, trying to give them some tenodesis so that they can have a little more independence. So we got two options, nerve and tendon transfer. The nerve transfer is a newer procedure, but it's pretty common now, so I wouldn't say it's experimental or anything like that. Well, I'll show you a video at the end, and if you're squirmish, maybe don't look at that video because it's a pretty big incision. But what we do is we find the nerves and then we cut the donor nerve and cut the recipient nerve and attach them under a microscope. We don't want that to get pulled apart for 3 weeks. So if we're worried about it, we'd splint them, but usually we can make it loose enough that we don't need a splint. So that's a really big pro for the patients. This doesn't work right away though. The nerves have to grow all the way down to the muscle. So we see early results at 6 months and full results at about 3 years. So it's very long. That's in contrast to the tendon, where just in this picture on the bottom, you take one tendon, sew it to the other. That you want to make sure it doesn't get pulled apart. These patients may not have enough strength to do that, so we don't splint them more than we need to, but often we do need to have some protective splinting. That tendon will start working right away, and we work with our therapists so that they don't get too much scar tissue and they can start activating it. So it works faster and it's usually stronger, but the problem is we don't always have a lot of tendons to move. So for example, you could renervate the posterior interosseous nerve, and that'll give you thumb and finger opening individually. But in the other picture where I've shown the muscle, you can only move one muscle into one set of tendons. So all those fingers have to move together. And to ask one tendon to move the thumb plus all the digits, it can just be a lot to ask for one tendon. So there's a lot that goes into this, and we give patients both options if they're candidates, and you can have a combination as well. So supple joints, critical for us, and then rehab. If you don't learn how to activate the donor tendon or the donor nerve to do the new function, it won't work. So that is critical. And again, we're grateful to the support of therapy on 58 and throughout the city and Lisa's team, who's she'll be talking about that next. So the tendon transfers, immobilization, that's a downside for patients. And then if you're going to put something for hand close and hand open, that can be hard to rehabilitate. So sometimes you need to do it in different stages. The nerve transfer, we can potentially renervate more. So one donor nerve can potentially give more muscles than one tendon can do. So that's the biggest reason we usually use this in spinal cord injury, is because we can get more out of it. And then we don't need to stage it. It'll just take time to grow in, but we can rehabilitate that at the same time without pulling on a tendon, for example. But the results take a long time. Tendons can rupture or get scar tissue, so therapy is important to kind of be in the middle, not too aggressive or not enough, and it gets scarred. And then the nerve downside is if it just does not reinnervate, then the patient waits and they get nothing. But usually that's rare. The biggest problem is if the nerve is not strong enough that we move, it may not be strong enough to reinnervate a new muscle. So nerve transfers for us, the most common ones would be moving posterior deltoid into triceps to give elbow extension, wrist extensor, so extensor carpi radialis brevis to give hand close, and then supinator to give finger and thumb opening. So we're trying to get hand and triceps for most patients, but again, we can customize. So we go into the nerves, we kind of dissect them under a microscope and then take the components that go to whatever we're moving. So very kind of delicate surgery. Tendon transfers. So for example, you can move piece of deltoid directly to triceps as a tendon transfer. You could move biceps to triceps, but you can imagine that's a hard one to retrain because you're flexing and extending your elbow at the same time. Wrist, we would often take brachioradialis and put that into extensor carpi radialis brevis, but then the elbow's got to be straight to give that wrist. So that can be a little bit funny. So sometimes we would, again, prefer a nerve transfer, then we don't need to keep that donor tendon extended. And then if we're going for hand close, if the patient has multiple wrist extensors, we would again go there. So take the extensor carpi radialis longus and put that into finger and thumb flexion. This one, for hand opening, you could move the small pronator teres into open, but you can see that that muscle is quite small, short. It doesn't technically work that well. So if the patient has a supinator nerve, that works better just for results. Nerve transfer results are modest. So we do tell the patients this, we do not want to overpromise, but when we see the results, they go from MRC 0 typically to MRC grade 2. So no function to usually being able to go against gravity. So they're not overly strong, but we're hoping that they can have some motion. And then in this study, for example, patients reported holding a bottle, maybe self-catheterizing, using their phone a little bit more, a little bit of pinch. So as long as that's kind of we're meeting the patient's goals, they are a good surgical candidate, and the results take a long time. So here's a picture. So at the top, you can see good MCP extension. You can see good finger close, and you can see some pinching. So those would be a good result for a patient that started with nothing. But to go through the big surgery and all the time, when they could use an assistive device, patients decide whether or not that's something they think would be beneficial. The tendon transfers are stronger, so often they'll get an MRC grade 3, so they can go against gravity. And they can do it a little bit quicker, but again, it's just if we have enough tendons to move around. So in this case, our first one, this patient luckily had awesome results with therapy. We were so impressed. He got his hands more supple. So we proceeded to move posterior deltoid to triceps nerve. We took brachialis nerve for hand close, and then supinator nerve for hand open. And on the other side, just slight difference, the wrist was stronger on that side. So we took a wrist extensor for hand close, which is our preference because that's just the most intuitive. And then in this other patient, and this is my last slide. I'll just show you guys this video it's kind of gory, but this is the incision. We got to find all the nerves and then we stimulate. And so in this patient, we also wanted to move to get ECRL, so wrist extension. So she had a few more nerve transfers done. That's why the incision's so big. But if you see here, I'm stimulating posterior interosseous nerve. So you can see the MCP joints and the thumb opening up. And then the next one I'm going to stimulate is the supinator nerve. So the supinator is the one we're going to take as the donor, and then we're going to put that into the posterior interosseous nerve to try to give the hand open. And we just kind of go through this protocol for each of the nerves and then connect everything under a microscope. Big incision, but it does sew up nicely at the end of the day there. So from there, I'll pass it over to Lisa, and we're happy to take questions after.
Perfect. Okay, so I'm just going to share my screen. All right. So I'm going to talk a little bit more about the rehabilitation after a nerve or tendon transfer surgery. And I'll also be giving some case examples. We're going to be talking a little bit about biofeedback because we tend to use that instead of FES. And then I'll finish up talking about the tendon transfer. So diving right into nerve transfers, there are generally 6 different phases. I find that I often will treat patients long term, and their therapy really can span for up to 3 years. So establishing a good home program is very important. I'll usually see clients once a week until their passive range of motion is full and they have all their necessary splints and we've established a really good home program. And then after that point, then I'll usually see them once a month for monitoring and progression of their home program. And clients are usually on my caseload for about 1 to 2, sometimes up to 3 years. So the first phase is the preoperative phase. And so before they get their nerve transfer surgery, we really want to make sure that they have very supple joints. We want to maximize the passive range of all of the affected joints and address any contractures. So I'll often teach them how to do some stretching, and we'll often provide them corrective splinting to try and address those contractures. We also want to strengthen the donor nerve, the donor muscle, and any other functioning muscles while we wait for the surgery. We could start some visualization exercises, and I'll talk about that in a moment. And then sometimes we also need to talk about desensitization and some sensory re-education. So let's dive in a little bit more about the visualization and motor therapy, because that is a really important part of the rehabilitation protocol. So other terms we use for this can be, we'll call it mental practice, mental imagery, or motor imagery. And so what we have the patient do is we want them to consciously and repeatedly imagine performing the movement without actually moving their body. Sometimes having them observe like a caregiver do the motion while they're imagining how to do it. Sometimes there's virtual reality, not as common with spinal cord injury patients though, but we are doing a little bit of that with arm amputees. And then mirror therapy. And now this is a little harder when you have a spinal cord patient where it's bilateral arms affected. And throughout this presentation, we are going to be referencing the MRC muscle power scale as seen here on the slide. And that's how we decide how we're going to progress through the different phases of rehabilitation. So now they've had their nerve transfer surgery, and typically about 3 weeks post-surgery, that's when we'll see these patients with the CAR program. And we consider them in their protective phase. So we do want to protect the nerve transfer, but the good thing is usually the surgeon will do the nerve transfer under minimal to no tension. So we don't actually have to worry about restricting the shoulder or elbow, but it's just something to make sure you read the operative report to find out, are there any considerations where we need to protect it? So in the rare circumstance, if they had a nerve transfer involving their axillary nerve, we might have to keep them in a shoulder sling for 3 weeks, but that's usually a rare circumstance. We also want to do some careful range of motion exercises to maintain their mobility. And we also want to be working on isometric donor contractions. I'll often start teaching them visualization exercises, and I have some very specific examples later in the presentation about what this means for these clients. We also want to focus on edema management, and so just doing positional drainage, maybe some retrograde massage, different compression sleeves or compression gloves, and just their positioning. And then lastly, working on desensitization. So sometimes we need to do a lot of touching of the area just to help to calm down the nerves. So then we wait, and then at some point, we're going to notice they're going to start to get a flicker or a contraction. And so that's what we would consider an MRC grade 1. And so now they are in the silent or corrective phase. So this is the very beginning of early reinnervation. There's no observable muscle contraction, but we can feel that flicker. So now it's really important because we want to regain cortical representation in the denervated muscle, and patient education and visualization is huge. And so we will call this their nerve activation exercises. And so what they're going to be doing is they're going to be visualizing the donor plus the recipient action simultaneously. So my example, and I have a video on the next slide, is if they've had a nerve transfer where it was axillary to triceps nerve, well, our axillary nerve helps abduct our shoulder, and our triceps is that elbow extension. So we're going to be combining those motions together simultaneously. We will sometimes use a mirror to help with that, but in spinal cord patients, since bilateral arms are often effective, the mirror might not, it's usually not as important, but having like a therapist or a caregiver help them with that demonstration can sometimes just help that brain connection. Also, while we are still in the silent and corrective phase, we want to still maintain the suppleness of their joint. We want to keep everything moving. So we're going to continue doing a lot of that passive range of motion and any corrective splinting to prevent contractures and tightness. We still want to work on strengthening their functioning muscles and also working on scar management. So here is a video of a nerve activation exercise. So this is an example for the axillary to triceps. So we're going to be doing abduction of the shoulder while visualizing their elbow extension. And we are going to be getting to do this bilaterally. And when you hear us talk about mirror therapy, sometimes, like if it was for other peripheral nerve transfer patients, if it's a unilateral limb affected, we will bring in that mirror to help us do this motion. So now a couple more months have gone by, and at some point they're going to move into the re-education phase. And so this is when the recipient muscle is starting to contract and produce movement. And so this is your MRC grades 1 to 2. So we're starting to see some of that active movement with gravity eliminated. You are still going to continue your nerve activation exercises. So you're going to continue that bilateral nerve co-activation exercises of moving both the donor with the recipient simultaneously. We're also going to look at starting active range of motion in a mid-range, because often that's a little bit easier for them. And you want to try and see if you can do it in a gravity eliminated position. Limb positioning is very important, and so oftentimes we'll get them using a table or just different positions because we want to try and take gravity out of the situation. I find we don't use slings anymore. We're just using a table or just changing their body positioning for that. You want to make sure you respect the fatigue. So we're often doing short sessions multiple times a day. And this is the patient doing this homework. And then we'll then often start to bring in a biofeedback unit, an EMG, if it is available to us. And I have more slides later in the presentation about biofeedback. And then after a few more months go by, then we go into the strengthening phase. So an MRC grade 2 to 3, so we'll often see that active movement. Now they're able to start doing it against gravity. And so the key things you want to work on during this phase is we're transitioning from gravity eliminated movement to now movement against gravity. And you really want to focus on functional movements that are important to the patient. So for example, if it was an axillary to triceps, oftentimes instead of just doing that nerve activation exercise, we're going to get them doing some functional reaching where they have to either abduct or flex their shoulder as they're extending their elbow. We also want to start to deactivate the donor nerve. because we want to start to unpair or uncouple those different nerves. And we really want to work on isolating the recipient nerve. So for example, if someone has had a supinator to pin transfer, typically supination with a wrist and finger extension, that might not be functional if you want to get some food to your mouth. So we're really going to be looking at, okay, well, let's bring that food to our mouth, but we want to keep our hand closed. We can also use biofeedback to decrease the donor nerve output. You want to watch for and correct any compensatory movements. And biofeedback, if you do have access to this, we will sometimes start to progress them from a biofeedback EMG setting to more of an ETS setting, where it's an electrical trigger stimulation using biofeedback. So the patient has to accomplish a certain amount of stimulus before the machine kicks on. And then the last phase is the endurance phase. So typically they are an MRC grade 3 or higher. So they're moving against gravity, they're moving against resistance, and they're just getting stronger. And so we're going to transition moving from against gravity to now adding in that light or moderate resistance. We're looking at increasing the resistance and endurance. You want to be mindful that the recipient muscle is not fully innervated and it will fatigue pretty quick. So we're going to do things like lower reps, maybe lower weights. Also, when we are getting them to work out, for example, in a gym setting, you can use that looking different adaptive cuffs with like a hook and a pulley system so that they can get a little bit better strengthening. Our biofeedback unit, we're often transitioning them from the ETS setting to the NMES setting. And we are continuing to work on functional activities and looking at deactivating the donor nerve. And so this is just a summary slide of all of the different phases and the big key points to take away. And it's important to know that this whole chart, this can take 2 to 3 years. And so I always tell clients, this is a marathon, not a sprint. And so now I want to get a little bit more into the most common nerve transfers. So oftentimes with spinal cord injury patients, we will see axillary to triceps, and that's to help improve our elbow extension. The second one being ECRB to AIN to help facilitate finger flexion. And the last one, supinator to pin, to help facilitate wrist and finger extension. Now, this article here, it has kind of some guidelines of when we will see some visible contractions and some functional movements. And so you're really seeing, if you look at the chart, it's taking them, 9 months, 12 months before you start seeing that visible contraction or functional movement. But I think it's important to note that this study was actually done for a regular nerve transfer client. And it's really important to know that with a spinal cord injury client, the time to visible contraction and function will be longer, and their outcomes are going to be a little bit less because they're typically only going to get to that MRC grade 2. So now moving into some case examples. So we had a C4 spinal cord injury, and this was a dirt biking accident. And this client had bilateral upper extremity nerve transfers. And so the 3 transfers that were done was the axillary to triceps, the brachialis to AIN and to FDS, and supinator to pin. So when they came through nerve clinic, they were at an MRC grade 1 to 2. So that those recipient muscles were just starting to contract and just starting to produce movement. So on my first visit with them, what I did was I taught them those bilateral nerve activation exercises. And I have some videos in the next slide. I also made sure to start their active range of motion mid-range and in a gravity eliminated position. I educated them about fatigue, and they would need to do a few reps multiple times a day. And then I did put in referral to the CAR program, because of the CAR program, we do have the biofeedback unit that we often use with clients. And then I also taught him how to strengthen his existing functioning muscle, which is his triceps. I recommended for him 1 to 2 visits per month for those nerve training exercises, and he did have a focus on his home program. So for this client, for the auxiliary to triceps, so you always want to do a donor plus the recipient. So the nerve activation exercise is that shoulder abduction with elbow extension. Then for the brachialis to AIN and FDS, you want to combine elbow flexion with a tight fist. And then for the supinator to pin, you want to work on supination while you simultaneously extend the fingers, the wrist, and the thumb. So those were the 3 nerve activation exercises that we taught this client. So the biofeedback unit we often use. And so this is just a picture of what our unit is that we have. And we often will use the EMG setting to start off with. And there's a lot of different games that we can play with the client. I will start biofeedback training when motor units are confirmed on needle EMG, and that's usually when they're around a grade 1 to 2. The electrodes will be placed on the recipient muscle, and the reference electrode can go anywhere. The negative black electrode I typically place near the upper insertion or the top of the muscle. And the red electrode I typically place on the motor point of the unit. So usually where the center of the muscle mass is. Sometimes you have to slide those electrodes around to find the best position. And your objective is to find the spot where the minimum amount of electrical stimulation will excite the greatest muscular contraction. So for this gentleman, I just chose one of those nerve transfers to show you how I would do biofeedback. And so I selected supinator to pin as my example. I've got the red electrode on the extensor wad motor point. I've got my black electrode near the upper insertion. And then this one over here, that's my reference electrode. You can put that anywhere on the body. Typically, I'll just put it somewhere distally on the arm. And we would start that biofeedback training when the motor units are confirmed on needle EMG or when we're seeing an MRC grade 1 or 2. So supinator to pin, the nerve activation exercise is they have to supinate while simultaneously extending their wrist and their fingers. And so this is just a video of me using the biofeedback machine. And so they're doing that nerve activation exercise of supination plus wrist and finger extension. And you can see on the EMG, you can actually see the recipient. Yes, it is firing. Now for these patients, it's going to be a lot smaller amplitude. We also have a couple different games that we'll play with them. And so one of the games we use, it's a little plane. And so they're going to be doing that nerve activation exercise to make the plane go up. And then they have to fully relax to let the plane kind of dive down. And there's little stars on the screen that they have to collect. And then lastly, I'm just going to touch on tendon transfers. So common tendon transfers after a spinal cord injury is You're going to see sometimes biceps to triceps, and this requires functional brachialis and supinator muscles. And the goal is to improve their elbow extension and improve any elbow flexion contractures they may have. Another common tendon transfer is brachioradialis to ECRB with a tendon graft. And the goal is to improve that wrist extension, but they will have to have an extended elbow to help with that wrist extension. And then pronator teres or ECRL or FCR to the FPL and FDP, just to improve that hand grasp or closure. And then finally, pronator teres to your extensor digiti, or your EPL and your abductor pulsus longus, and that's just to help improve the hand opening. So what are your goals of therapy prior to a tendon transfer surgery? Well, you really want to make sure you address any joint contractures and stiffness, because the joint that the tendon transfer will move has to be really supple, and we have to maximize their passive range of motion prior to surgery. A tendon transfer surgery will fail if the joint has become stiff. So you really need that supple joint. And you can also work on strengthening the donor muscle. And then after they've had their tendon transfer surgery, the general guidelines is we are typically going to have to immobilize them in a splint just to let that tendon heal. And so usually we'll have them in a protective splint for about 4 to 6 weeks. We'll also start to work on gradual range of motion once we've had clearance from the surgeon. And so we're looking at gradually improving their motion to really restore that function. And once we're starting to move them, we're gradually weaning out of that splint. So we don't stop that splint cold turkey. We gradually wear it less and less. And then as the tendon heals, strengthening exercises are introduced to improve their grip strength and functional abilities. Typically, we're starting strengthening around week 6 to 8. And then we also really want to work on functional activities. So we're really getting them to do movements that are important to them and part of their daily life. And so we'll have them practicing grabbing different objects in the clinic, doing different types of grasp and release and different pinching. So those are kind of the big concepts post-surgery for tendon transfers. If at any point in the future, if you have any nerve transfer clients that you would just like to ask some questions about, I often will consult with other therapists. And so here's my email on the screen. Feel free to send me an email. We have some handouts on the biofeedback unit and general concepts for how to use it. Or even if you just need to discuss, well, what kind of nerve activation exercises should I be doing? I can also help problem solve that for you as well. So now we'll open up the floor to any questions. So if you have any questions for Dr. Elzinga or myself, we'd love to answer them.
Great, thank you both of you. Excellent presentation. I do have a couple of questions in the Q&A. First of all, does FES work as a good modality for rehab for nerve and or tendon transfers?
I find typically we're moving more towards the biofeedback unit, because we want to know what the client's ability is. So we really push for a biofeedback unit, especially in nerve transfers, instead of the FES unit. So that's kind of been our big push in the rehab protocol.
Thank you. Our next question is from Allison. Where do these patients go after their nerve and tendon transfers if they have limited function compared to their previous function? Are they going to rehab? Are they going to subacute hospitals, to hospital, home?
Yeah, so first of all, like we'll talk to the patient about that beforehand, just to make sure they kind of know what to expect. We've been really lucky because if we try to intervene on these patients early, that we've been doing the surgery at my hospital, South Health, but then still sending them back to Unit 58, which is wonderful because the staff takes excellent care of them. That's the best place. If they're already at the outpatient stage, We would discuss with the patient if they feel they can manage at home, that's great. If they feel like they need to be admitted to hospital, we can arrange that too. We have some rehab facilities. They're not always easy to access, but certainly that's an option as well. Just depends, yeah, what kind of support the patient has. If it's a nerve transfer, maybe like they'll have some pain and some incisions, but it may not slow them down as much as they might think. But certainly if they're in a splint, that could be a little bit more challenging. So we'll definitely try to work with the patient, and all of those are potential options depending.
Great, thank you. Do you discourage developing a tenodesis grip if you know the patient will have nerve transfer surgery?
Yeah, so certainly, like if the patient has active wrist extension, we still want them to, use that tenodesis, but we would like it to be a supple tenodesis. We don't want it stiff. We would like them to try to use it without getting stiff if they can, because like we said, if they get too stiff, they won't be a surgical candidate. So yeah, that is the different kind of paradigm for this.
Do you set patients up with biofeedback at home, or is it only in therapy sessions?
So most times, like we do try and encourage the patient to purchase their own biofeedback unit. And we do have a handout that we give clients. The one channel basic biofeedback unit is around $1,000. And then the one that we use here that has 2 channels, it's about $2,500. A lot of times our clients are able to find funding through their private insurance for that. And I would say about 90% of my clients end up purchasing their own biofeedback unit because it is something we would like them to use every day. It's just as part of their daily therapy at home.
One more down here. Is the surgery done under general?
Definitely. Yeah, it has to be under general because we're actually stimulating the nerves to identify them. So if we do a block, then we can't necessarily stimulate them. And we give it up to the patient if they want to do one arm or both or stage it. Like they could just do triceps in one surgery, hand in the next. But generally, we do offer to do all the sites bilaterally, just so the patients don't have to go under multiple anesthetics, multiple rehabs, that kind of thing.
Is there any evidence-based modalities to help improve nerve regrowth and function, such as electrical stimulation or BCI, brain-computer interface?
Is there evidence for that for upper extremities?
Yeah.
Certainly there are like some groups. I haven't seen it. I don't think I've seen it in Canada. It's in Europe, mostly, where they are trying to use, more brain interfaces. It's still quite experimental, and from what I've seen, like you have to implant, stimulators either peripherally or in the brain. And so there's problems with like wires, corrosion, those types of things. But I think that's going to be coming.
Interesting. And one last question. How typically long is that surgery?
Yeah, good question. So it depends what we do, but usually we would get 2 surgeons, so we're both working on one arm to be as efficient as we can. If we're going to move like triceps nerve and both of the hand nerves, probably total surgical time 4 or 5 hours.
Great, thank you very much. Oh, one more just popped in. How early in their recovery do you anticipate that the patient may be a candidate for nerve tendon transfer? I do feel like you answered this a little bit, but what should we facilitate that discussion as early as possible?
Yeah. So we're really grateful to the physiatrists who work like on Unit 58 and the equivalent at the Glenrose, who first of all identify patients who may be candidates and then evaluate them. Certainly we want to allow patients to recover from their acute injury. So we don't want to rush them into anything. And if they're having, spontaneous recovery, we're not going to ideally intervene until they've sort of maximized. And once the patient really identifies what their goals are. So yeah, the earliest that I would think would be 3 months, but that's even early, probably more like realistically 6 months. But yeah, encourage tenodesis at the start. So yeah, if they again have that intact wrist extension and you can just use tenodesis, but without letting the fingers get stiff, that would be ideal. Because we do want to leave it as an open possible surgical possibility. If they get stiff, it's hard to sometimes get them back into the surgical candidacy because it can be hard to regain that. So Yeah, so I guess we're just lucky because now our physiatrists are kind of helping with that. I'm happy to, we are happy to see patients at Foothills early on to see if they're candidates, and then if so, carry on with that kind of plan. And if they're not a candidate, just because the patients who are not candidates typically don't have any donors, so they're quite a high level injury. But most patients would be a candidate, and it's just a timing of when that would be. So. And then is there better outcomes with staging? So if you're going to stage again the tendon transfer, you might have to stage it because you don't want to be working on like wrist flexion and then you're tearing the finger extensor, for example. So those we have to stage because we want a good outcome with the tendon transfer. But for the nerve transfers, there's no reason to stage it. It's just as good to do it all at once, except for the rehab. So, they'll have to work on the biofeedback for multiple sites, for example. So just a lot of work on their part every day, ideally kind of working on that. And then nerve transfers for bladder, sexual health. That's really interesting. Lower extremity. That might be coming. I've seen some experimental talks at our nerve conferences, but nothing really great at this point. Nerve transfer to the diaphragm. We have done that here in Calgary. So if you have a phrenic nerve that's not working, within that 1 year window, you can move an intercostal nerve from between the ribs to the phrenic nerve. And that would be either to help the patient, if they have a unilateral, maybe be less short of breath. If they're a bilateral, maybe even get them off a ventilator dependency. The intercostal nerve is not that strong. Again, it's kind of a complicated surgery. But if you think you have a patient that needs a phrenic nerve reinnervation, the biggest problem is we usually don't get them within that 1 year window, but we're quite happy to evaluate them for surgery at the peripheral nerve clinic.
Great. Well, thank you so much for your presentation, both of you, and thank you to all of our presenters today.